So my name is Nguyen. I'm a fourth year PNWU student, and my presentation is going to be about opportunistic self-injectomy in women who are low risk for ovarian cancer but are undergoing a hysterectomy for abnormal uterine bleeding or pain or something else, or undergoing sterilization via tubal ligation. So as far as the presentation outline, we'll talk a little bit about ovarian cancer. We'll talk about how bilateral self-injectomy plays in reducing ovarian cancer with hysterectomies and sterilization, and then just a little summary. So as far as the pathogenesis of ovarian cancer is very complex and heterogeneous, mainly because the ovary is heterogeneous in its development. So part of the ovary is developed from the coelomic epithelium, another part from subcoelomic mesoderm, and then another part that's the primordial germ cells, which turn into more of the yolk sac tumors. We'll be mostly talking about serous or epithelial ovarian cancer, and that involves more of the high-grade serous adenocarcinomas. And that actually develops from the epithelium overlaying the ovary that also overlays the serosa of the fallopian tube. Besides the ovary, you have the fallopian tube, and that's developed from a Mullerian derivative, and that also plays into how complex ovarian cancer can be. And so there's a bunch of different types of ovarian cancer. Again, we'll be handling just high-grade serous ovarian cancer that's not hereditary today. So if you're a BRCA1, BRCA2 mutation carrier and there's a history in your family, there's going to be a different type of management and prevention for you specifically. But if this is a low-risk woman who's undergoing a hysterectomy or tubal ligation, then self-injectomy will definitely help them. So out of ovarian cancer, 70% of it is going to be ovarian epithelial cancer. 70% of that is going to be high-grade serous adenocarcinoma. And that actually has been proven to come from the fimbriae of the fallopian tube. And so there was a study done in 2007 which found that 20 out of 30 ovarian cancers that were serous epithelial cancers had 20 out of 30 of them, when they dissected the fallopian tube and removed the ovary, the malignancy was actually in the tube before it got to the ovary, and 5 out of the most malignant out of those 30 cancers had the same p53 mutation. And so currently the literature is very in support of serous adenocarcinoma coming from the fallopian tube. Here's a little bit of fallopian tube anatomy. You have your fimbriae here, which in a self-injectomy is very important to take out the fimbriae and then go as far as you can. It's not as important to get the intramural part, but as much of the fallopian tube that you can get out, the better. So the epidemiology is that the average age of ovarian cancer is about 50 years old, and it's the 5th leading cause of cancer deaths among women. As far as gynecologic cancers, it's the most malignant and has the highest mortality rate. You have about a 46% chance of surviving after 5 years if you have ovarian cancer. Overall, though, about 1.3% of women will develop ovarian cancer. So the diagnosis is pretty hard to make because the signs are very nonspecific. You have pressure, you may have pain, or you may have nothing at all. There's no succinct labs. You can use a CA-125 to follow ovarian cancer, but it's not a diagnosis. Imaging is good because you'll be able to see like teratomas or complex cysts, but the real definitive diagnosis is removing the ovary and the fallopian tube and doing histology slides to diagnose and stage. That's unreasonable to do that in every woman, of course, and it's unreasonable to put every single woman under an abdominal CT just to see if she has ovarian cancer. And so we're still trying to see how we can better our diagnosis, and there's current research ongoing to develop diagnosis. When you do have ovarian cancer, the treatment is pretty intense. You have to have a hysterectomy with bilateral esophageal oophorectomy, and you have to have lymph node dissection of the para-aortic lymph nodes and the pelvic lymph nodes to stage your cancer. And if it's really bad, you have to debulk whatever disease that you can see, and then possibly undergo chemotherapy as well. So there are ways to prevent ovarian cancer. One, obviously, is to do a bilateral oophorectomy and esophageoectomy. But that becomes very concerning because most women get hysterectomies around the age of 45. So they're still premenopausal, and if you remove the ovaries too early in a woman's life, you put her at a lot of risk, and those risks include premature menopause, coronary disease, cardiovascular disease, osteoporosis, cognitive impairment, and you increase chances of other types of cancer. But the prevention of ovarian cancer is 88%. And so someone with a BRCA1, BRCA2 mutation with a very strong family history, this may be the solution for them. But in someone with low risk, like what are OB/GYNs supposed to be recommending to them, especially if they're gonna get a hysterectomy? And so in 2015, Nguyen et al. Did a study, a continuous study with patients in British Columbia. His team used 28,000 data from 28,000 women undergoing hysterectomies or tubal sterilization, and put them in a Monte Carlo simulation, basically a math box that kind of spits out ovarian risks and prevention. And so with a hysterectomy alone, you get about 20% protection against ovarian cancer. But if you added a salpingectomy to it, it's 38.1% more effective than the hysterectomy alone at preventing ovarian cancer. And then if you go to the green box, so great, it prevents ovarian cancer, but at what cost? And actually, with a salpingectomy and a hysterectomy, the costs are a little bit lower, and that's because most hysterectomies with salpingectomies are laparoscopic, and that reduces the cost of the OR and the cost of having patients stay for less time. In earlier research in about 2013, McAlpin did kind of an operative and preoperative measures of how hysterectomies with salpingectomies go, and there are actually no differences in hospital readmissions for patients. There's no difference in the need of blood transfusion, and if you can see the length of hospital, the length of hospital stay is actually significantly less with a salpingectomy than it is with a hysterectomy alone. The only problem is the operating room time there is a significant difference of an increase in operating time. We'll talk about more recent trends later in the presentation. So then, that's hysterectomies. What about patients who undergo tubal ligation for sterilization? So there's a whole bunch of sterilization methods that are permanent. So if you remove part of the tube as in a tubal ligation, it's pretty effective. only 6.3 people out of 1,000 in 5 years would get pregnant from tubal ligation. And so there's no data on how effective a bilateral salpingectomy is for sterilization, but if you assume that it's nearly 100 for tubal ligation, you can assume that it's also nearly 100 in bilateral salpingectomies. And when we compare these two for prevention of ovarian cancer, a tubal ligation reduces ovarian cancer by 30%, whereas a salpingectomy can reduce it by 50%. And this graph shows that basically it's a two-way sensitive analysis in which if you look at, on this side, if you do a tubal ligation, the risk reduction for ovarian cancer is 0.3, but at the same time, if you did a salpingectomy, the risk reduction would have been 0.4. So basically, this graph is just saying that salpingectomies are more effective at preventing ovarian cancer. There are a couple of cons. With a tubal ligation, you can do a thing called tubal reanastomosis if the woman changes her mind, says, I want to try to get pregnant again. In salpingectomies, you cannot do that. And there's also a 1% chance of inadvertent oophorectomy, which would make things a lot more worse for the female, but that is very rare. Let's see. So again, the Nguyen study, it showed that the salpingectomies are 29.2% more effective than a tubal ligation in preventing ovarian cancer. And there is a pretty significant cost difference, about $400 more. And I really attribute that because most people, when they do tubal ligations, what you can do is a mini laparotomy, which make 2 incisions on your abdomen, pull out the tube, cut kind of thing. It's very easy. But with a salpingectomy, you have to go in laparoscopic, and so you add these additional OR costs. But as the technology changes, I think that this decrease might go down. So looking ahead at some more data from McAlpin, you see that there's no difference in hospital stay, readmission, the necessity for blood transfusions. And this, for salpingectomies versus sterilization, there's actually really not a big difference in OR time, just maybe a little bit in OR costs. And this is just some data just again listing how many or how much each method is in preventing ovarian cancer. Let's go back to the previous slide. Okay, and so in this slide you'll see that you have the life expectancy here, and you see that there's only a 0.02 difference of life expectancy in each, and you're probably wondering to yourself, that's not really that much at all. But if you put all of this into comparison with other types of screening and prevention, with HPV screening and cervical cancer screening, you add about 0.005 years of life expectancy in prevention of cervical cancer. So that's about less than 2 days, which is less than what you see here. And the number needed to treat for a hysterectomy and salpingectomy to prevent 1 case of ovarian cancer is 273, whereas in salpingectomy for sterilization is 366. And in comparison to kind of the rest of what's going on in life, it takes 324 women to get the Gardasil vaccine to prevent 1 case of cervical cancer. So salpingectomies with hysterectomies or tubal ligation is very formidable in ovarian cancer prevention when you're comparing it to other cases of how cervical cancer is prevented and how that has made a change in the United States in comparison to countries that don't have it as cervical cancer prevention. So if we can get this would be nice. So the trends of salpingectomies in the latest study in August of 2016, it actually shows that physicians are more leaning towards offering their patients salpingectomies, and the data shows that there's no difference really in the cost of hysterectomies with or without sapropectomies, and that the OR time is actually getting so close in time, especially with robotic assistance, that there's now trending towards like there's really no difference as far as the hospital-wise to just take out the tubes while you're taking out the uterus as well. So as a summary, sapropectomies, when you're also going to do a hysterectomies or doing tubal ligation, provides more ovarian cancer protection than doing it alone. And the trends are that now there's not going to be any differences in OR time or hospital stays, readmissions, or blood transfusions for the patients. ACOG, which is the American Congress of Obstetricians and Gynecologists, recommends that patients that are undergoing hysterectomy without oophorectomy or tubal ligations should be offered the choice of sapropectomy, and the physicians should discuss the potential benefits of preventing ovarian cancer in these women, because the data are so strong in showing how protective it can be with ovarian cancer prevention. These are my works cited, and the floor is open to any questions.
Can you go back quite a ways? 80% of something was, so you might want to go to end the show and slide up.
Oh, okay, gotcha.
That far back, yeah.
The bilateral oophorectomy? That one?
Yeah.
Yeah.
Bilateral oophorectomy, and you did.
Sorry. There we go.
Salpingectomy. So taking out your tubes and ovaries only
Altogether.
reduces your rate of ovarian cancer 88%.
Yes.
What are you getting ovarian cancer for if you don't have it?
So if your ovarian cancer is already seeded, and
So
you
that's
just
not,
don't
I
diagnose.
mean, that makes it sound like you're gonna develop, it should be 100% or 90-some% prevention of ovarian cancer. If you take it out and you have ovarian cancer afterwards, you had ovarian cancer to begin with.
Right.
I mean,
I know, it's a little weird, but it just says 88%. And I'm not entirely, and it kind of goes back to the fact that the development of the ovary is so complex, and so, there's a lot, there's a lot of different derivatives that can go into
so
ovarian
you're
cancer.
basically saying with that statistic that some people who have this procedure done, ovarian cancer is already developed. Is that your interpretation?
That's my interpretation, and then part of it is that it could just develop from somewhere else too, because there's metastasis to the ovary that still counts as ovarian cancer.
Could you have peritoneal cancer that is ovarian cancer, like it's
nature.
already metastasized to the peritoneum wherever,
Yeah.
and so you have ovarian cancer of the peritoneum?
Yeah, but I guess my question is if you're looking at primary prevention, you don't measure cancer that's already occurred as part of primary prevention.
Okay.
Because if you've already got the cancer, you don't fall into a primary prevention category. You're a whole different subset of you've got ovarian cancer.
Yeah.
So it's a weird statistic.
It is a weird statistic, and I'm also wondering, this statistic does not separate BRCA1 and BRCA2 from normal, from people without that mutation. So if you have that mutation, all bets are off. There's weird stuff that happens.
And there was one other, scroll down just slowly a little bit. There's one other number I wanted to, because these are the things I think you'll get asked questions on if you do it as an audition rotation. So basically, I don't know if I see it, but so basically, if you're gonna do, the options are do a tubal or a whatever,
Self-injectemy for
self-injectomy,
sterilization.
for your sterilization. There was one there that was, if you're doing a hysterectomy, it made it sound like there's hysterectomies done that leave the tubes.
There's very commonly, yeah.
Okay.
It's pretty common, especially if you're doing an abdominal hysterectomy or vaginal hysterectomy. Laparoscopic, especially robotic assisted, is way easier to take the tubes out. I mean, it's easy to take the tubes out vaginally and abdominally too, if you do it all the time. But most of the time people just,
Snip.
yeah, leave the tubes there and then just take
So
the
does
tubes.
ACOG have a recommendation to stop doing that?
ACOG has a recommendation that if you're doing a hysterectomy, you should really offer your patients the choice of doing a self-injectomy as well.
I mean, what's the benefit of not doing that to the patient?
There's no benefit.
Yeah, so, I mean, that's one of those things that if ACOG, I would think that ACOG would say, you know, they always give you the level of evidence,
No.
take the tubes. It's not
Yeah.
a choice to the patient at that point. If
It's,
they're already taking their uterus.
yeah, it's pretty vascular around the ovary, the fibria of the ovary, and so that's what usually gets left behind. And that's bad because that's where the cancer is, but because it's so vascular, a lot of providers will just tie off at like the isthmus and just take off the uterus and leave the vascular part there because they don't want to mess with it.
Seems like it would be one of those things you're doing harm, or you're potentially doing harm, leaving.
Yeah,
And then what about the delayed oophorectomy?
so the delayed oophorectomy is for
Take the tubes now, go
yeah,
back to
for
the
like a
ovaries
sterilized,
later?
yeah, and that's more with BRCA1, BRCA2 mutation carriers, because we'll take out the tube and prevent as much as we can, and if you do develop ovarian cancer, we take out the ovaries before it metastasizes.
Allegedly.
Yeah, allegedly, yeah. And so,
So I was thinking another potential risk that you had mentioned is the inadvertent oophorectomy.
Right.
And that's a 1% risk is actually pretty high. So can you talk more about how that
Yeah.
happens?
So it's a 1% risk, and there's not a whole bunch of literature that says why there's that 1% risk. Patients with previous abdominal surgeries they tend to be, and you'll see in surgery where there's adhesions all over the place, so omentum's flying everywhere. And if you're not used to doing the surgery and seeing anatomy that's so mangled up, that's where you can run into some inadvertent oophorectomies.
I would think it would be the risk of one ovary coming out might be 1%. The risk of both
Yeah.
should be quite small.
Yeah, and when I was in Guyana, I scrubbed in with the surgery to take out a uterus for hysterectomy. And we did accidentally, like I didn't do it obviously, but I observed someone accidentally
Bring everything.
bringing everything out and basically ligating the ovarian artery
Unilaterally.
unilaterally, but then the other ovary was already, the other ovary was not good to begin with anyways. So it just happened, these things happen because in that case, the patient's fibroid was as big as my head and the uterus was still stuck in there, and so the anatomy was totally distorted.